Good morning, everyone. Welcome to another fantastic brunch in our healthcare maintenance and IBD series. This series is supported by education grants from Janssen, Pfizer, and Takeda. I'm Dr. Aline Charabaty. I'm an assistant clinical director of the Division of Gastroenterology at Johns Hopkins School of Medicine and the founder of Monday Night IBD. I am joined today by my amazing colleague and very good friend, Dr. Tiffany Taft. She is an associate professor in the Division of Gastroenterology and Hepatology at the Northwestern University Feinberg School of Medicine. Tiffany, welcome. Thank you for joining me today.
Thank you so much for having me.
I'm very excited about our conversation today, but before we start, our faculty disclosure are on the screen. Today, we really wanted to focus on a very important topic that I am so excited that more and more people are talking about. And Tiffany has been one of the person that really educated me on the importance of mental health and how to address mental health in patients with IBD. So I'm very excited that she's here today. And I'm very happy that we're talking about this. I mean, I think we are all as clinicians aware that IBD affect a person's life way beyond the GI tract. It really is a chronic illness that affect a person living with IBD at so many levels, financially, physically, emotionally, socially, anywhere from choosing the food you want to eat to be able to be functional at your work or attend your class or have a family and juggle all the demands of life, in addition to also the demands of the disease itself and the symptoms and the flares and how to stay in remission and the clinic visit and the office visit and all this. So I can only imagine how much it can affect someone's overall mental and emotional health. But Tiffany, I really want us to dive into more details. What do we know about the effect of inflammatory bowel disease on the mental health of patient living with IBD, anywhere from term of depression and anxiety, but also what we're talking more about, and you're bringing more and more to light, is a post-traumatic stress syndrome.
There's definitely a lot of research on depression and anxiety. There's enough research to do like meta-analyses of meta-analyses at this point, and we consistently see a quarter to a third of people will have what we would call significant depression and anxiety symptoms. But I think what I see in clinical practice is more subclinical depression and anxiety, that if they filled out one of these questionnaires in a study, they may not reach that cutoff score, but there's certainly still distress happening. And so I think that really isn't appreciated as much in these statistics.
I mean, already saying that a third of our patients living with IBD have depression or anxiety is a huge number. So even, by using the, very strict criteria, this is a huge number. And it really highlights the importance of why we need to address this topic, but not just as a topic, conversational topic here today, but really how important it is for us to address this in our clinic with our patient and really ask the right question. But I want us to talk more about the trauma from the medical flare, the medical tests. We had recently a conversation on Monday Night IBD where patients share their experience about, how many CT scan and MRI and colonoscopy and blood work they had done, and really gave me pause that I'm just writing a test order, but the patient is going to live that experience anywhere from the frustration to get a schedule, to get it done, to the anxiety waiting for the test result, the conversation, etc. All that package that comes with me just ordering one test. I would love for you to tell us more about what happens in people's mind and how they're living their disease, their flare, their medical care, when we're trying to think we want to reach mucosal healing, and they're trying to survive all these tests and those flares that are affecting their lives.
Yeah, it's such a delicate balance, right? Because we do need testing. We do need to know, right? You need to know. You can't just look through their abdomen with your eyes and see what's going on. So the testing is necessary, but unfortunately, anywhere from symptoms to getting diagnosed to these tests to hospitalizations, all the things that happen with IBD are all potential sources of medical trauma. In our interviews from patients, certain themes arise in terms of what's traumatic, and some of it made sense and some of it was kind of surprising. So the things that made sense were hospitalizations, were surgery, potential ostomy, emergency type surgeries where the patient doesn't have time to really think through what's happening, were very stressful. And it really mattered how that was communicated by the attendings, whether the surgeon or the GI on call or whoever. If not communicated properly, what patients then did was they got on Dr. Google. So they're sitting in their hospital room. They were just told they may need a colectomy, and they go Google that. And they're there by themselves. And then nobody is really asking them, how are you doing? How's your anxiety? So to have trauma, you have to have a perceived threat to life or bodily harm. And so being told we're going to take your colon out is a perceived threat to life or bodily harm. But other things that came out is maybe not as obvious, were like colonoscopy pictures at diagnosis. So the patient is being discharged. They've got this report, and there's these pictures of their colon that might not look so great, and they don't understand what's going on. It really hasn't been explained to them because they're coming out of anesthesia, and they're just looking at these pictures like, oh my God, what is going on in my colon? And it's supposed to be informative, but can be very scary. And then everything else, bleeding, surgery, scars, tests, NG tubes are described as torture by patients. Around 25% to 30% of patients also have symptoms of PTSD or post-traumatic stress disorder, which aligns with the anxiety and depression statistics. And so that's a lot. That's on a level of cancer. It's way above the national average of post-traumatic stress disorder. It's higher than combat veterans. So it's concerning. And so now we're at the point of, what do we do with that? And I think there's treating that, but there's also, I think, preventative things that we can do as clinicians.
Absolutely. I think, you really put in the right way. It's prevention, because with inflammatory bowel disease being a chronic illness, we know that it's going to be a point of time where there's going to be flares or hospitalization or surgery or colonoscopy. So this is not just one trauma, it's recurrent trauma through a lifetime. But also, like you said, Tiffany, is really asking the patient, how do they feel about this? And I think this is something we're absolutely missing. We're driven by, we're doing the right thing for the patient, to control things, to improve things. But we're missing the whole point, is that we're taking care of a patient, and true patient-centered care involve, the emotional and mental health of the patient on that moment and then later on. And I think I really appreciate the fact that you mentioned that, some of those trauma comes from what's expected, right? The big stuff, surgery, ostomy, perianal surgery. But I think as gastroenterologists, we're not thinking about colonoscopy. We think about colonoscopy as being a hassle, but we don't think about colonoscopy also inducing trauma, and getting colonoscopy frequently, whether it's time of flare or during maintenance, is a stress. So I wonder if we sometimes are misinterpreting what our patients are doing, because they are anxious maybe to get that test, because they're anxious about the result, because they are depressed and maybe feel like whatever they're going to do is not going to change the course of the disease. And we're labeling as non-compliance, no-show, difficult, demanding. And I wonder if sometimes we are really labeling our patients, in a very negative way, when what they're dealing with is anxiety and depression and post-traumatic stress disorder. What do you think?
Yeah, I would agree with that's probably happening a lot of those times. Not all, obviously, there are always other factors that lead people to behave in certain ways. But I think if I'm anxious, and anxiety is a symptom of post-traumatic stress disorder, I'm not going to go somewhere that's going to make me more anxious. One of the symptom clusters of PTSD is avoidance. Like, that's what we call it, avoidance behaviors. So people's nervous systems go into red alert, like fight or flight, threat response. Imagine trying to sit in an office talking with a physician when your brain is going, you need to leave now. Threat, go. And everybody knows what the threat response feels like. We've all had that startle, oh my God, my heart is, racing. That's what's going on internally. There is some research that shows that patients with IBD tend to be more stoic, or they control that to present in a favorable way, to probably not be labeled as, oh, this one's really anxious, because then it gets into, they're not going to believe me. They're going to think I have symptoms because I'm anxious. I'm calling 5 times because I'm anxious. You see how it all kind of weaves together. And there's just so much going on that, can't be captured in one interview or discussion. But yes, short answer, yes. Mental health concerns are behind difficult, non-compliant, all these things that interrupt your ability to take care of your patients.
You just kind of pointed out that, maybe sometimes patients are reluctant to say that they are anxious and they're stoic, or they put a good face, partly maybe because they're worried we're going to label them as anxious. And so any symptoms is anxiety, and not take their symptoms seriously, but also possibly because of social stigma, that unfortunately we still have about mental health, and other reasons. Maybe they think that the gastroenterologist is not the right person to talk to about that. And at the same time, we know that as gastroenterologists taking care of patients with IBD, we're often the primary physician for these patients. And I think most of us, well, not every one of us, but a lot of us have difficulty addressing mental health in general, and even more so in our clinic, and even more so in busy clinic or busy days. So I'm wondering, as a clinician taking care of patient with IBD, whether we're, nurses, nurse practitioners, physician, OBGYN, GI, surgeon, etc. What is the best way you think to approach that topic with a patient, in a way that, feels comfortable for everyone?
Yeah, so I think patients should be screened. And I know that medical record systems have built in depression and anxiety tools like the PHQ-2, 4, there's many numbers of the PHQ, the GAD-7. I think you can give those at certain increments throughout your patient's care as just part of questionnaires that you give. If you're given the short form IBDQ, throw in the PHQ-2 and the GAD-7. I think screening for post-traumatic stress or post-traumatic stress disorder is critical post-hospitalization, because that has emerged as the place that most trauma happens. It does happen in other instances, as we talked about, but the hospital stay is really the highest risk. And so there are some screening tools for PTSD. The primary care PTSD screen is a short, I think 6 or 7 item questionnaire that can be given that asks about symptoms of PTSD. And a score greater than 3 is suggestive of further questions, further investigation. Recognizing that not everybody's going to be honest on these questionnaires, right? So we can only rely on questionnaires and so much. So I would say, if you're still feeling like something's not right, so things that maybe you probably already recognize, a lot of one-word answers, poor eye contact, not a lot of questions when you're having pretty heavy conversations, is a sign of shutting down. And that's that freeze, or they added fawn to fight or flight, which is, what does a fawn do? I'm just going to be real quiet and gentle, and I'm going to go, and then they go home and they have their other responses. So looking for lack of engagement with you in conversations that really would be a little bit odd not to have questions about or responses to. So you could ask, that was a lot of information, how you feeling right now? And some will answer and some won't. So you don't have the time, unfortunately, to pull it out. But even asking that question, recognizing how stressful it is, might not be enough for them to say anything, but it might be enough for them to go, okay, she gets it. And then if they do open up, what can you do with that? And I think that's also a concern people have when I talk about this, like at conferences, like, well, that's great there, Dr. Taft, but now what do I do? I don't have a psychologist in my practice. And I don't know if you have one at Hopkins or not, before I continue. Like, how do you do it at Hopkins? Not to put you on the spot, because I come from a place with 5 psychologists embedded
Well,
in GI.
let me just say that there's a need. There's always a need. And but you know, before you continue, you bring up a great point that I have never had a patient not appreciate the fact that I'm bringing that topic of how they're feeling. And absolutely, patients are not going to start a therapy session with you as their gastroenterologist, but they do appreciate it, you understand, and then that gives you the tool to guide them in the right direction. You know, before you asked me if we had a psychologist at Hopkins, what I was going to say is that there's always a need. And that's, I think that's one of the biggest challenge, is really getting our patients to see the right psychologist, right? Because you know, a psychologist who's focused on either chronic illnesses or GI illnesses, or and have them available. I want you to tell us what we can do. And again, even if you could tell us what we can do, maybe in, you know, as gastroenterologists, things that maybe we can be comfortable starting patients on, or, you know, directing the patients. And I want to hear, you know, any resources that could be available to our patients.
So we're never going to have enough GI psychologists. In the Rome Psychogastro Directory, which is at romegipsych.org. It is a vetted directory of clinicians who specialize in working with patients with digestive diseases. Most include IBD in that list. There are, last time I looked, around 400 to 500 people globally in that directory. How many patients with IBD are there in the United States? 3.5 million-ish. Granted, not all need psych, but if 20 to 30% have significant mental health problems, someone do the math for me on that real quick. It's a lot, and we don't have the resources. So things that the gastroenterologist can do that does not require a PhD in clinical psychology, relaxation skills, things like diaphragmatic breathing. My colleague, Dr. Reel at the University of Michigan, has a fantastic 2 to 3 minute video on YouTube that has over 2 million views now on how to do diaphragmatic breathing for digestive conditions, or just diaphragmatic breathing. Very simple. And then there are apps that can help reinforce the habit. There's one called Belly Bio. There's, I'm not, you know, I don't get any kickbacks for mentioning particular apps, but there are just guided breathing apps that are free, where I don't have to pay like a subscription for other things that are a little bit more sophisticated. Use the technology that's out there. But you have to talk about it in the office. You can't say, well, go download this app and go do that. Show them how to do it. It takes under a minute to show someone how to do diaphragmatic breathing. And then if you really want to up your game, you can do progressive muscle relaxation, which again, plenty of videos on the internet, guides. It's very simple. It involves purposely tensing and relaxing different muscle groups. And it takes about a couple of minutes. You don't have to do the whole body. You just have to show them how to do it. And it's very easy to learn. You guys have learned way more complicated things than progressive muscle relaxation. Getting comfortable with spending a few minutes on those. And then when they come in next, how's it going with that? Check in. Don't assume that they're doing it, because they might not be. And let them know it takes about 2 to 3 weeks or so to even notice any benefit. A lot of people give up on this stuff quickly because they're like, it doesn't work. I don't feel any better. I'm like, well, how many times did you do it? 4. Okay. Did you learn to ride a bike in 4 attempts, or how many times did you have to practice? So putting it into those types of terms, it's a skill, right? I got to learn how to relax, which is strange, but it's what we need to do. Those are things you can totally do in your visits, and I highly, highly recommend that. Beyond that, I don't recommend trying to do any type of psychotherapy. So I recommend the relaxation strategies, which for some people are sufficient. Then it comes to, how do I refer to somebody? And if you don't have that access, right, you don't have the embedded psychologist, which is very rare still, then you have to find people in the community. And there are therapists who absolutely specialize in chronic medical illness, as you said. There's a whole field, subspecialty of psychology called health psychology or behavioral medicine. So just like medicine has subspecialties, psychology and social work has subspecialties. And so you got to find those people. And there's a lot more of them, which is good. And they are perfectly equipped to work with an IBD patient. So looking at therapist directories and knowing how to read profiles. Some people will say, I do it. I do everything. And it's not true. And so you have to look for special training in behavioral medicine, look at the profile. Are they talking about chronic illness in their profile? Not just if they checked it off on a list of things that they can work with. And it doesn't take that long, but then you have to reach out to them and say, hey, I'm Dr. So-and-so. I really need someone to work with my IBD patients. How do you feel about that? So there is some upfront work, but I feel like if you can get 2, 3 therapists in your area, depending on the size of your area and the number of patients you see, you'll feel more comfortable when these topics come up because you go, oh, I can send her to Dr. So-and-so or social worker so-and-so. That person's awesome. And you can go, here's their card, here's their information. And then when they come into their next visit, see if they were able to connect, or, you should get a contact from that therapist. Thank you for the referral, et cetera. We do the same types of stuff. Those are my suggestions in a system that is just very limited, unfortunately.
Well, these are great suggestions. This is more than I was aware of, and I'd love to actually learn some breathing. I know we all need it. I need it before getting on a plane. So I'm definitely going to check that YouTube video when we're done with this, because I think we all need help at different time of our lives. Yeah. Tiffany, this was just an amazing conversation. I know that both clinicians and people living with IBD are benefiting from this discussion. I think the takeaway message is for us clinicians to really be aware that every one of our actions, our tests, our steps, and every event that a patient with IBD go through is a source of trauma. There's so much data showing that patients with quiescent disease, if they have depression, anxiety, they're at higher risk of flares. And then, flares, again, like you pointed out, are source of medical trauma, depression, and anxiety. So we get into that vicious circle. So communicating with our patients, explaining things clearly, but also beyond the medical communication is really saying, like you said, how are you feeling about this? How are you doing? And really mean it.
Yes, I absolutely. I think, I've witnessed this, like I said, for a very long time. And I would say within the last 5 years or so, I've absolutely seen a shift in the conversation. And I think we can attribute that to a few things. Patient advocates on social media really trying to push the conversation. Physicians like you who join with them and say, hey, we should be talking about this, and making it aware, making people aware of these concerns, but also disseminating proper information, right? There's definitely a growing interest and a groundswell of a combination of all these factors and forces that I think mental health will not just be awareness of anxiety and depression, but start to do deeper dives into the mental health that is much more than those two words. And I think the next 5 years are going to be even better.
Definitely your expertise and your voice and your advocacy, along with the advocacy of patients, really being proactive about really, letting this topic, be in the forefront of good patient care and providing our patient with IBD with the right quality of life and with the right life that they deserve, has been tremendous. So I commend you for that. And I really thank you for spending this morning with me. And thank you for everyone for joining us today. Don't forget to check out our mental health and IBD tutorial that's posted under the Monday Night IBD handle. And make sure to claim your CME credits by completing the post test and the evaluation. Thank you, everyone. Thank you, Tiffany, again.
Thank you.